What's up, everyone? Welcome here to another episode on the podcast of the Heart Warrior Project. I'm Loeys, your host. I'm also a cardiac arrest survivor. And here on the show, I chat with fellow survivors to share their story, their journey. Or sometimes I will invite cardiac health experts on the show, like here in this episode. Now, these episodes are Q&A episodes, so listeners like you can send in their question to me, which I will then ask the cardiac health expert. Now, this episode is actually, in a way, a special one for a couple of reasons. First of all, it's actually two experts that I have here on the show. So Dr. Saenen and Dr. Loeys, they're actually going to introduce themselves. I didn't want to mess it up, so they will do a better job on introducing themselves. And another reason why it's quite a special episode in a way is because it's actually Dr. Saenen. He's my cardiologist, so he follows me. It was actually very interesting for me, at least, to interview my cardiologist. Thank you, for everyone who sent in their questions. It's really because of the questions that people send in that I can do these episodes with cardiac health experts. If you want to ask the next cardiac health expert a question, then check the description. As in the description, I will put a link to our newsletter, because in the newsletter, that's where I will send out an announcement. You can also go directly, though, to Heart Warrior Project/newsletter to also find the newsletter and sign up. Or follow us on Instagram at Heart Warrior Project. That's, those two places is where I mainly will bring out the announcement for an upcoming cardiac health expert. I just also want to thank Dr. Saenen and Dr. Loeys for making time to do this episode. Because you gotta know, we recorded the episode at 7 p.m. And they had already a whole day of work behind them. So, yeah, really, really appreciate it that. If you're listening, both Dr. Saenen and Dr. Loeys, I think I can speak for almost every cardiac arrest survivor listening right now, that we really appreciate it when doctors like both of you go the extra mile to do an episode on a podcast like the Heart Warrior Project to provide information and to put it more out into the world through a podcast like this. So again, both of you, thank you for making some time. All right, now let's dig into the interview with Dr. Saenen and Dr. Loeys. Please enjoy. Before we maybe start with some of the questions that people send in, could you both, first of all, explain what it is that you do? And in addition to that, if you want, of course, because I'm always curious to just ask cardiac health experts, what got you interested to start, on this path of becoming a doctor and doing what you do today? I don't know, maybe Dr. Saenen, if you want to start.
Yes, so thanks for having me. At the moment, I'm a cardiology consultant in the University Hospital of Antwerp. In doing so, I am an electrophysiologist. That means that I am treating patients with cardiac arrhythmias or dysrhythmias. Mm-hmm. The treatment consists of advising people to have lifestyle modifications, treating patients with medications, but also doing invasive procedures, meaning that we treat arrhythmias by changing the circuit in the heart by doing ablation techniques.
Yeah.
Top of that, my main interest in arrhythmias are arrhythmias that cause sudden cardiac death. So people that are seemingly completely healthy without seemingly having never had any symptoms, that suddenly had a collapse due to malignant arrhythmias. And to try and find the reason for this collapse, there's also a familial dimension to that. So in that sense, I am involved in the cardiogenetics clinic here in the hospital, together with my colleague Loeys, who is sitting next to me, who's a clinical genetician. Yeah. And I think by combining the genetics together with the cardiology discipline, I think it is really an added value to try and identify causes for sudden cardiac death, to come to better treatment of the patient that had the sudden cardiac death and survived it, of course, but also for the family members, and to try and prevent sudden cardiac death in as many people as we can.
Yeah, yeah. Which is actually how we know each other, right? Because I'm actually a patient with you, so
yes.
Yeah. And if there's something actually like what got you actually interested to start, to step on this path, because it's a long journey for both of you to be where you are today. Is there something that motivated you, inspired you, or in general on that?
Yeah, for me personally, it's quite general, I think, or it started off as quite a general interest in learning to know how the human body functions, and based on that, how to learn to understand when things go wrong. And of course, I got hooked up in cardiac diseases, in getting to know how the complex organ of the heart functions, and of course, what happens if arrhythmias occur. And of course, some of these mechanisms are hereditary, so also the complexity of that, also the dimension of the familial dimension and the genetic dimension, the molecular dimension for me was what really got me interested in taking this road to cardiac electrophysiology combined with cardiogenetics.
All right. Okay. Very interesting. Dr. Loeys, for you, if you could also explain in some words what it is that you do.
Yeah, thank you very much for hosting us. So I'm in origin a pediatrician. I trained as a pediatrician, but very soon because in pediatrics genetics is also very important, became very intrigued by the genetic origin of life. Actually, the whole reason I started doing medicine goes back all the way to a teacher in high school.
Wow, really?
Who was who was teaching biology, and he recommended reading a book. I don't know if you know the book. It was written by Christian de Duve, one of the few Belgian Nobel Prize winners, and that described actually the origin of life, and it dealt with the organelles and also DNA. And I read this book, and from that time on, I really knew I wanted to do genetics. But in Belgium, that was not so easy, because when I finished my training as a pediatrician, genetics was still not yet a recognized specialty.
Okay.
Most of the people that were working in genetics at that time came from another discipline, pediatrics or OBGYN or internal medicine. But I decided to go to the States and learn genetics, and I was very fortunate to be in one of the top centers in the States, which was Johns Hopkins in Baltimore, where I had a fantastic mentor, Hal Dietz, and it's also the place where Victor McCusick was. He was considered as the father of medical genetics, and
really?
He started an online inventory of all diseases that have a genetic contribution to it. So that's how I got interested. At the place where I trained as a pediatrician, there was also a strong interest in connective tissue diseases. And one of them is called Marfan syndrome, which is a disease that is associated with aortic aneurysm, so a dilation of the main vessel, and if that becomes too big, dissection, and unfortunately most often leading to sudden death.
Yeah.
And so when I went to Hopkins, I went to a place where they had a very strong history in that disease. And it also led to the fact that I was fortunate to describe a new condition that looked like Marfan syndrome, but is now called Loeys-Dietz syndrome. So that spiked my strong interest in everything that was genetics and related to the heart and the vessels. So after I finished the training there, I came back to Belgium, and I moved to Antwerp in 2010.
Mm-hmm.
I think at that time, geneticists were still considered as a very awkward species. And
really?
Within the cardiology department, everybody was looking at us and thought, what is he going to do here in the cardiology department? But fortunately, there was one colleague, and that's Johan, who really believed in the power of genetics. And I think in 2010, we started this clinic together. We also do really also physically together the consultations. And that has been proven to be a very important decision. And over the years, the clinic has grown tremendously, and now we have too much work to do it with the two of us, and the team is really expanding. So that's my road into cardiogenetics.
Wow. So it's a clinic that you both started?
Yes, in 2010. I can still remember the first patient that we were seeing together, which was a patient with a very bad hypertrophic cardiomyopathy, and we were able to show a genetic basis of that.
Okay, very, very cool. So thank you both for introducing yourself. So let's dive into some of the questions that people send in, and I'm gonna copy the question in the chat so you can both read it as well. I'm gonna read it out loud so everyone listening can also knows the question. So this is a question from Henriette. My question is, why do I have heart disease? My parents don't, and my son does. Now, this is a very simple sounding question with probably a very complicated answer to it. Now I will add one more thing to it, because I have arrhythmogenic cardiomyopathy, but I'm the only one in my family who has it. So it's also something that I've been very just stunned about. Like, why am I the only one? So, yeah, why do some people in a family develop heart disease and others not?
Yes. So maybe I'll start with the answer to that question. I think, first of all, we have to realize that not all cardiac disease is genetic, of course. We know that there is also a significant group that's more related to lifestyle factors. But the distinction between those two is mainly made by the age at which it presents. If you look in the older population, there the major cause of heart disease will be problems with the coronary arteries, and there, of course, lifestyle factors are very important.
Yeah.
But if you go to the younger people, let's say below age 55, then we know that more than 80% of these heart diseases do have a genetic component to it. So there the picture is completely different. It's not because of lifestyle factors, or often you will not notice that there is any abnormal lifestyle factors, but it's mostly determined by a genetic alteration. So you can look at it as a mistake in the architecture of the heart, either being structural or in the electric circuits that are present in the heart. And then within that big group of genetically determined heart diseases, we can distinguish also many different conditions. And most of them will have what we call an autosomal dominant mode of inheritance. What does that mean? Autosomal means it's unrelated to the sex, so both males and females can have it. Yeah. And dominant means that it is sufficient to have a genetic alteration in one of the two copies that we have of each gene. Yeah, so we call that a mutation or a pathogenic variation. Nowadays is used more often. And that alteration will lead to an altered protein, either in quantity or in quality, and those proteins do have an important function in the heart, either being a structural molecule and building up the heart muscle, or being important in the conduction. We call these most of the time ion channels, where they have variation, leads to abnormal or less present protein in the heart. For some genetic variants, we do know that they are sufficient to cause the disease. So you only need that genetic variant to lead to a disease. But for other genetic variants, we consider them more as a kind of predisposition that makes
Like a
you
vulnerability?
more prone to, yes, like a vulnerability, exactly, to heart disease.
Right.
And the one that you were mentioning, arrhythmogenic cardiomyopathy, is a very typical example of that. That we know that most of the time you need the genetic variation that's needed to create the vulnerability, but you need additional acquired factors on top of that. And that could be, for example, in athletes, extreme exercise.
Right. So there needs to be an
or substance
environmental
abuse.
component.
Exactly,
Yeah.
exactly. Yeah. And we do not always know what that factor is, but sometimes we do know and we can identify it. And that explains also some of the variability within a family. So it can be that you inherited the genetic vulnerability, but if you don't encounter the specific triggers or the specific environmental factors that provoke the disease, then you will not develop it or develop it much later than somebody else in the family. So that is how we can explain that within the family there is variability in the symptoms and in the way the disease is presenting itself. In genetics, we call that penetrance. It means the chance that you will develop the disease when you have the genetic variation, and that's variable for different diseases. And for some diseases, the penetrance is very high, but for others, it's quite low.
What are actually some other triggers that could trigger the vulnerability in the gene?
We do know that alcohol in itself can be a specific one. It's estimated that alcohol in itself is toxic, but if you have a genetic variation on top of that, it's more likely that you will develop the cardiac disease. Some medications, we also know that they can provoke disease. A typical example of that is long QT syndrome and Brugada syndrome, where there is a whole list of medications that if you have a genetic predisposition and you take a specific medication on top of that, at that time you will develop the arrhythmias.
Sometimes it's strenuous exercise in athletes, as Bart already mentioned. Sometimes it's fever. So for instance, in Brugada syndrome, there are these very specific genotypes or mutations that we know are temperature sensitive. So that means that they will not, or almost the risk of developing an arrhythmia based on this mutation is lower at normal temperatures, but when the patient gets ill and develops a fever and at high temperature, the risk for arrhythmias increases. So there are many of these factors. Sometimes the genetic predisposition, so the genetic vulnerability, is not based upon one gene, but sometimes there are multiple genetic defects at the same time in the same person that also increases the risk for this for the manifestation of the disease. And we do see these families where we have generations where there's nobody that has any symptoms, that doesn't have any cardiac abnormality, or at least detectable abnormality. And then suddenly there's one person that is affected and that displays the abnormality, the cardiac disease, and also the symptoms, and the risk for arrhythmias that can lead to sudden cardiac death. It's actually often the case.
So I think the variability of presentation can be an explanation of the story that was presented. Another explanation is that sometimes genetic variations occur for the first time. So for example, in the case that you just described, it's possible that the patient has developed a new genetic alteration. When you make a sperm and an egg, you need to copy 3 billion letters, and nature makes mistakes.
Which is a mutation then?
Where that mistake is. Yes, exactly, or just a variation.
Okay.
And then, of course, once you have it, you can pass it on to your son. And a genetic variation always has to start somewhere, and it can be inherited, but it can also be what we call a de novo. So it means it happens for the first time, and that happened then during the making of the sperm or the egg cell.
Okay, and what about emotional stress? Is that something that could also trigger?
Yeah, so stress in itself is a state of whether it is emotional or physical, is a state of hyperadrenergic tone. And we know that elevated adrenaline tone can increase the risk for arrhythmias. And of course, in a normal patient with a normal heart, usually this doesn't, this will not cause any problem. But in patients that already have an electrically lesser stable heart, in some of these patients, this can really lead to arrhythmias. For instance, in patients with CPVT or in certain types of long QT syndrome, if there's a very high stress burden, either physically or emotionally, sometimes this can lead to arrhythmias, which in normal patients this shouldn't be the case.
Okay. Again, it's a easy sounding question that is very, very complicated. But okay. Let me give you another question from someone else. These were actually two questions that the person sent in. But let me ask the first question first. I'll just read it. This is from John. What are some of the main causes of sudden cardiac arrest? I ask as I'm learning to just accept that it happened. Heart attack victims know it's plumbing, which seems logical. Ours was electrical, but why? I'm an avid runner who I thought was very healthy until 6 months ago. I had my sudden cardiac arrest. Good news, the person who saved me is a Belgian. Go to Belgium. So I also added one thing more to it. What is the main cause of sudden cardiac arrest? And also, but maybe you answered this already a bit, but why do healthy people have it?
So I think first it is important to understand the heart. So what is the heart? It is a muscle that contracts about 100 times a day. And it has a couple of components that are important. So first of all, it is a muscle. And this muscle, of course, needs oxygen to be able to function. And this oxygen is delivered by blood in the bloodstream through the coronary arteries that are surrounding the heart muscle. There are 3 coronary arteries. And of course, if there's a clog in one of those arteries, or what we call a stenosis, or an occlusion of those arteries, the oxygen delivery will get impeded. So that means that there will be mismatch between the oxygen demand of the heart to let the heart muscle function and the oxygen delivery. So this muscle also has to be driven by electrical stimuli, and the heart itself creates those stimuli inside the right atrium. And those stimuli will migrate over the heart exactly in the same way, following the same path for each of those 100,000 beats a day. And if something goes wrong with this electrical stimulus migrating over the heart, this can cause an anomaly in the rhythm of the heart, and this is what we call an arrhythmia. So we have the muscle function, we have the arteries that are there to deliver the oxygen to the muscle, and we also have the electrical system that is there to drive the function of the heart, to drive the contractions of the heart in a very concerted way, in a very organized way. And if something goes wrong in one of those components, this will cause heart disease. So the main cause for sudden cardiac arrest or sudden cardiac death, as we know it, in 60 to 80% of the cases is due to a coronary artery disease or a clot or a stenosis in the coronary artery that causes this oxygen, this lack of oxygen in parts of the heart that we call a myocardial infarction. And this myocardial infarction will cause electrical instability that can be detrimental, and that can cause sudden cardiac arrest due to ventricular arrhythmias that we call ventricular tachycardia or ventricular fibrillation. If we go, so these kinds of disease, of course, there can be genetic predisposition, but most of the most important part of the etiology of this myocardial infarction, which occurs usually at later age, is due to acquired factors such as our Western way of living with a lot of hypercholesterol diet, fatty diet, not exercising enough, and things like that. But if we go and look in the younger population, as Bart already mentioned, patients that are younger than 45 years of age and that suffer from sudden cardiac arrest, the cause of sudden cardiac arrest is different. So mostly it is due to primary electrical diseases. So these are the diseases where there's something wrong with the electrical function of the heart. So this electrical stimulus that takes another route through the heart that causes an arrhythmia. And if the arrhythmia is such that the heart is no longer able to beat efficiently, this will of course cause a drop in blood pressure. And if this is only for just an instant, then this will cause syncope, so the fainting of the patient. And if the arrhythmia resolves itself, then the patient will come around after a couple of seconds. This is what we call syncope. But if the arrhythmia persists and the blood pressure remains too low, this syncope will evolve into a sudden cardiac death or sudden cardiac arrest. So in the youngsters, the main cause for sudden cardiac arrest is primary electrical disease. At a little bit later age, the sudden cardiac arrest is due to cardiomyopathies. So these are diseases of the heart muscle itself, where something is wrong in the building plan of the heart muscle that can cause the heart chambers to widen, which we call dilation, or to thicken, which we call hypertrophy. And some of those cardiomyopathies will also predispose the patient to electrical disturbances that we call arrhythmias, and it's those arrhythmias that will cause sudden cardiac arrest. And then there's a smaller proportion, about 1 to 2% of patients that also have sudden cardiac arrest due to aortic dilation. So this is the large artery that comes out of the heart and that gives way into the systemic circulation. And if this aorta dilates, so becomes larger in diameter, due to Laplace's law, the wall stress becomes higher, and at a certain point, like a balloon, the wall of this vessel can tear up. This is what we call a dissection, and this dissection can lead to a massive bleeding inside the body. And if this happens, then this is also one of the causes for sudden cardiac arrest. So the main reason, of course, in our Western world is coronary artery disease or myocardial infarction with arrhythmias. But in the younger population, younger than 45 years of age, there's about 80% chance of a genetic cause, and these are primary electrical diseases, cardiomyopathies or cardiac muscle disease, and thoracic aortic aneurysm dissection.
Is lifestyle the most common? Is lifestyle one of the most common reasons for cardiac arrest, or is it just a component?
In a sense, I think it is the most important one. Yes. So that is also why cardiologists are always saying that you have to keep a healthy lifestyle, because indeed, so myocardial infarction is by far the most important cause of death. Still, even more important than cancer, unfortunately. And of course we know there is a genetic component there, but it is not dominant. So the dominant reason for having this atherosclerotic disease in the coronary arteries is due to lifestyle. Arterial hypertension, diabetes, obesity, cholesterol, smoking, and not exercising enough. So not so healthy lifestyle. Yes.
Yeah. Wow. I am gonna paste the second question from John. Is it true that only 1 out of 10 live who suffer SCA? I'm still trying to get my head around that stat. Now, what actually, I mean, I'm sure that's depending on which country, right? Like in Belgium compared to the Netherlands, the statistic is quite different, right? No? Like...
It's worse in Belgium, yes.
It's worse in Belgium, right? It's about like 10%, and in Netherlands about like 20%?
Yeah, in some regions, but that's due to a special program, I think. Yes, in some regions. So I think in general we can say that the success rate of resuscitation for sudden cardiac arrest is about 5 to 10% at best. And of course there are these exceptional regions where they had a project to try and enhance that by doing certain things to try and enhance that. So what's actually the reason? So Belgium is a very densely populated country, and even in our very densely populated populated country, it takes about 11 minutes for an ambulance to reach an accident. Yeah. So on average, 11 minutes. Now, as I mentioned, if you have a sudden cardiac arrest, there's a drop in blood pressure, and if the drop in blood pressure is such that the brain is no longer perfused enough, then brain damage can occur. And we have about 4 minutes before irreversible brain damage occurs. Yeah? So that means that if we are just waiting for the ambulance, it takes 11 minutes. By the time the ambulance is there, there's been irreversible brain damage that is so tremendous that usually the patient will not survive. And that's actually what is happening in most of the cases. So it is true, about 5 to 10% that survive if a resuscitation has started. So it is super important that that everybody learns to do CPR, to do resuscitation as fast as possible. So first, to recognize when a patient is in distress, when there's a resuscitation situation, that's the first thing, and then fast do adequate resuscitation. And even then, so the chance of survival are not so good. And also of those patients that survive, it is important to realize that only 1/3 actually survives without detectable brain damage. So about of those 5 to 10%, it's only 30% or 1/3 that makes it out unscathed or seemingly unscathed.
It's actually such a crazy statistic to hear each time again, because it's so bad. It's really bad, right? Is there anything, if you could have like an influence on this, that you would want society as a whole, to improve on? Is there anything on that you would say?
Yeah. Absolutely.
Yeah, make resuscitation an obligation as a course in schools. I think that would probably be, and then have people repeat it every couple of years, another training. I think that's probably the most important. Yeah,
because nowadays, if you look in Belgium, if there's a resuscitation situation, 50% of the bystanders are just not doing anything. Because they are afraid of doing something wrong, or they are just waiting for the ambulance because the doctor is coming. So I think there's a large threshold for people to start the resuscitation because they are afraid to do something wrong. And that, I think there's only one thing that you can do wrong, and that is just standing there and not do anything. So it is really important that we all, as a society, learn to take care for each other and to learn to recognize an emergency situation for an individual and then do the right thing and learn resuscitation and then, of course, do it adequately when the situation presents itself.
Yeah.
Can I add another one?
Sure.
I think another one that we are confronted quite often in the unfortunate situation where the patient dies is the absence of an autopsy. I think it's really within our culture that people tend not to think about it or give permission for it. And I think for us as a cardiogenetic clinic, that puts us very often in a very difficult situation because a couple months later after a person died, we do see the family and then they come with the question, what caused this sudden cardiac death? And if there's no autopsy or even better, if there would be no DNA, then it's very difficult for us to know what exactly was the cause of that and to give a good advice. We can, of course, do clinical screening, but it's so important in that difficult situation. We completely understand that, and it's not the easiest thing to talk about, but that an autopsy is performed and that we can really know this is the cause. If the autopsy is performed, a DNA sample can be preserved, and that really helps us a lot in the counseling that we can give to those families to estimate the risk that there is for the surviving family members. And too often it's said, oh, it's not important, or don't worry about it. It was hartaderbreuk, how do you say it in Belgium? And it's not a diagnosis. It doesn't even exist. So I think that's another very important one, that we should change the mind of people, and also the government has a role, because for example, a molecular autopsy is not reimbursed in the current system. There is a very strange law that says that it's only reimbursed when the person died while exercising, whereas most of the people that have sudden cardiac death do not die during exercise. They die during sleep and in rest. So and it's not even implemented. It's a law that exists, but there's no, how do you call
That's
it?
an actual law?
in yeah, it's a law. Yeah.
Wow.
Or a proposal for a law. Yeah.
Yeah.
Yeah, so it doesn't make sense at all. I think doing a molecular autopsy in any young person below age 45 that died should be reimbursed by the government, because it gives us, in up to 30% of the cases, it does give us answers that we could not get from a classic autopsy.
That's a good point, actually. Yeah, it's also an important one to talk a bit more about, because people might not like to talk about it, but as you pointed out, it does help us to move forward. So in that sense, it's very important.
Exactly. And to prevent recurrence
Yeah.
in the family.
Yeah, so sudden cardiac death actually is one of the most important red flags to show that something was wrong, especially, of course, in the youngsters.
Yep.
Of course, if the patient was 75 years of age and had chest pain and chest discomfort, already had a myocardial infarction 10 years ago, and there's a sudden collapse, the chance that this was a new infarction with an arrhythmia due to it is very high. But if the patient was younger than 45 years of age and had a sudden cardiac death, this really is a red flag for a hereditary disease. So there's probably other patients in the family of that patient out there with a similar disease, or at least a similar predisposition, and may have a similar risk profile for also developing similar arrhythmias, sudden cardiac death at a later stage. So really important not to dismiss that, because these are the opportunities that are at the moment so often missed. Opportunities, even though the patient did not survive, which is really unfortunate. But this is really an opportunity to look at the family and to try and prevent a similar event from happening in the relatives.
Yeah. One thing that I wanted to ask a bit more about, so you pointed out CPR, right, in the beginning, as a very important thing for us to all know. What did actually the Netherlands do, or that region in the Netherlands, what did they do differently, or what do they do differently for such an increase in survival rate? Is it just because they have been trained all in CPR, or is there something more that they have done that you know of?
Yeah, I think it was also. I think there was also. I'm not fully aware of the details of the project, but I think it was trying to increase the reach of AEDs as fast as possible, and also the response time, because response time is really key in this. So everybody can have a collapse at any time, at any place. So it is really. It all comes down to being there as fast as possible within 4 minutes. And then giving good CPR, and if you can have an AED on site, this device can give an electrical shock that can stop the arrhythmia, so the electrical disturbances in the heart, like you're pushing the reset button of your computer. So the heart can restart, and if the normal heartbeat restarts, the blood pressure can come up again. The brain will be perfused again, so it will be protected from further damage if there's any already, and then of course the patient can come around and life can go on again. So it all comes down to response time with the right person that knows how to do CPR, and if possible to have an AED there as fast as possible, because this is really the solution of treating these arrhythmias. And if you do that in a good way, I think Holland, or the region in Holland, has shown that we can really make progress. So I think it's a very important message there, that we can do better, and that results are there if we invest in it as a society. And knowledge is one thing, technology is another thing, and response time, I think, is the third one.
Yeah.
So I think they had a system with a mobile phone where
Yeah.
there was a victim that based on the localization of the victim, that people that were in the neighborhood got like an alert on their phone, and they then go to, because they're the closest people that can give the first CPR and know where the AEDs are. So I think that's how they did it.
Yeah, I think that was in there. That's true. So. Yes. Yeah, it's really unfortunate. I mean, like how many more people have to, in a sense, die from a cardiac arrest before, I guess, the government really is like, okay, we should invest more in this. It's actually kind of ridiculous that we have to. I mean, that this is not in school yet, CPR, and it's so easy to implement. So it's kind of ridiculous that it's not in there. Yeah.
Yeah, we also think that probably it's also cost effective to prevent sudden cardiac death.
For sure.
Have been some studies also in Ireland.
Well,
to do there.
Yeah. Let me ask. This is actually a question that I had. Also gonna paste it in the chat. So, I've had, several ablations in the past. You've done a few on me, right, Dr. Sana? So, and there might possibly be another one in the near future. Now, of course, correct me if I'm wrong, but so far it seems like there is just two ways to treat heart arrhythmia, which is medication or an ablation. Are these just the two options, and is there any new therapies in development that are also shown to be effective for the near future?
Yeah. So medication and ablation are, of course, important pillars of the treatment of arrhythmias, but of course the treatment is more wide, it's more broad. So of course we have for some kinds of or specific kinds of arrhythmias, we have lifestyle modifications.
Right.
Sometimes it is also avoiding triggering situations, for instance, exercise in some cases, or swimming in some cases, or treating fever, as we mentioned already, for Brugada syndrome as fast as possible to avoid arrhythmias. Of course, we have medications that can reduce the adrenergic tone in the body, which we call beta blockers. We have also antiarrhythmic drugs to that. So these are medications that can directly affect the electrical activity in the heart to try and reduce the electrical instability in the heart. And that's also a way to treat arrhythmias. And then, of course, we have ablation. So the ablation is to first map the substrate and also the electroanatomical changes in the heart that make up a circuit for an arrhythmia. If we can find it, then we can ablate the circuit. Ablation means that we destroy the critical part of the circuit, disconnecting the circuit in a sense, to avoid the arrhythmia from reoccurring.
Yeah.
Because an arrhythmia follows the stimulus in an arrhythmia follows a certain path. This is the arrhythmia circuit. So are there new therapies being developed? So yes, within ablation, until now we had two main ablation techniques, which are what we call thermal ablation techniques, where we use either freezing or burning, really heating the tissue to create lesions, to interrupt these circuits. At the moment, there's a new technology that we call pulsed field ablation, where we use little electrical shocks that cause electroporation, so it makes little holes in the cell membrane of the cardiac cells, and it causes a different kind of lesion that can also treat arrhythmias. At the moment, this pulsed field ablation is mostly used in the atria of the heart for arrhythmias in the atria, like atrial fibrillation. The experience in the ventricles at the moment is not that large, so it is being tested, and the first experiences are there, but it is still in a very early stage. Are there other ways of making lesions to interrupt electrical circuits? Yes. There's also a technique where we use radio therapy. So there's a nuclear radiation therapy to destroy certain parts of the heart tissue, especially if they are very difficult to reach with the ablation catheter, either from the endocardial, from the inside of the heart, or the outside of the heart. Sometimes we have this very thick tissue, for instance, in hypertrophic cardiomyopathy, where we cannot reach with our thermal techniques the point of interest. So that's where we can use radiation technology. And then, of course, we also have, so in the future there will be gene therapy. These things are under development, they are under research for certain diseases such as long QT syndrome. I think there's a study ongoing in Italy, but this is still something that is experimental and is not in routine practice at the moment.
Yeah, gene therapy is quite new.
Yes. Yeah. I think genetics has created a lot of hype on that. So I think one of the main issues with cardiac diseases is to be able to deliver the therapy to every cell in the heart.
Yeah.
Like, we do have the technology now to correct genes. You may have heard about the CRISPR technology, where you cut out the mutation and you replace it with a normal sequence. We can do that, and we increasingly can do that with high accuracy, meaning that we don't expect to see many corrections in places where we don't want them. But the main problem is still to deliver this to every possible cell in the heart. So you have the machines to correct it, but you need the right trucks to bring it to the right place. And that's where we still have to make progress. I think things are evolving, and there is progress being made. But if you compare it, for example, with eye disease, we know that the eye is very localized and it's very easy to access, and it's much easier to correct all the cells in the eye because you have almost direct access. That's much more difficult in the muscle, and specifically also in the heart muscle. I think where we do see a lot of progress is by understanding better the biology underlying these diseases, because once you've identified the gene, you know which protein is missing or not functioning very well, and you can try to find therapies that work on that mechanism rather than trying to correct the genetic mistake. For example, the new therapies that are there in hypertrophic cardiomyopathy, they really work on the mechanism of the contractile proteins that are not functioning very well, is largely due to our understanding that's based on a genetic understanding of the disease, because you know exactly which molecules in the heart are not functioning well, and then you can try to design drugs that compensate for these malfunctioning proteins.
And then, some years ago there was a big buzz about stem cell therapy. Also, they were injecting stem cells inside the myocardial infarction lesions directly in the heart. And in vitro, this looked really, really promising. But the problem is, of course, that these cells are not always recognized as your own cells. So they are actually by the immune system. They are just disposed of by the immune system. And after some time, they're no longer there. So it creates some extracellular matrix, but that's about it. So it really hasn't given the results that people were expecting.
Yeah, and I think another issue is to get the cells to the right maturity that they need to replace other heart cells. So we can culture cardiomyocytes, so heart muscle cells starting from stem cells, but they don't reach the same maturity as they should in the heart.
Because stem cells,
an issue where we still.
Stem cells are new cells that you're implementing in someone.
Yeah, there's methods now to make stem cells starting from a regular blood cell or a skin biopsy. So that's possible. We can reprogram blood cells or fibroblasts originating from a skin biopsy to become a stem cell, and then you can differentiate that stem cell into the direction of a heart muscle cell or a cardiomyocyte. So that's all possible. But what we do see is that those cardiomyocytes, so these heart muscle cells that we create, don't have this exact same characteristics as the heart muscle cells, because it's a kind of logic that it takes 9 months to grow a baby and then a whole life of functioning, that it's hard to mimic that in a dish to create these heart muscle cells. And progress is still made, but the maturity of those cell types is still under investigation, and we need still to make progress before they will be also, or before they can be used as a treatment strategy.
What is actually something that you both find very interesting of developing therapies?
I think that gene therapy, if it works, is of course will be the holy grail. If we are able to inject the gene that has been corrected inside the cell machinery, so it produces the correct protein, that will be fantastic. I think that's the holy grail. If you can do that, then you can really stop the disease in the patient in front of you. At the moment, if we find a mutation in a patient, we can prevent transmission to their children, to the offspring. So that's what we call primordial prevention. But this requires, of course, IVF techniques. And it is reimbursed in Belgium, so it's possible. And we give the options to patients that have a class 4 or class 5 disease-causing variant. But of course, for the patient already in front of you, having the disease, at the moment, as we already mentioned, we can give medication, do lifestyle modifications. We sometimes use ablation techniques. But it would be wonderful if we would be able to correct the underlying problem. And at the moment, this is not possible. For some diseases, this is not that worrying. Some of those are not progressive, but some of the diseases are really progressive, where the muscle really deteriorates over time and over the years. So if we can already stop this deterioration and freeze the heart in the state that we find it, that would already be a huge advantage.
So I think as a geneticist, I'm looking at the genetics. I think we can still learn a lot from a principle that we call genetic modifiers. So we always talk about this one gene, one mutation, but of course we have 21,000 genes, and that one gene never behaves by itself. It's always in the context. And there is some interesting observations that we can make both in humans, but for example also in mouse models, where we see that a phenotype, in this case cardiac condition, can completely disappear when you change the genetic background on which this mutation is acting. So that's quite interesting, because it shows us that nature has ways of compensating for the presence of that one mutation.
Oh, wow.
And I think by learning more about that, we can try to mimic them afterwards by medications or other strategies. So I think nature itself can teach us some lessons.
And of course, we're only looking at the DNA level. We're looking at mutations at the DNA level, but there is lots more going on at the one level higher, at the RNA expression and protein expression, that we really, it's just the beginning of our knowledge. If we find an answer, it's always the first step to more questions. So
Hey, I'm just going to interrupt the conversation here between me, Dr. Saenen, and Dr. Loeys for just a short moment. If you want to, support this project, which allows me to continue doing it, consider, supporting us through buying some of our merch. Like, we got this really comfy hoodie with our logo on it. We got mugs. This one is actually more meant explicitly for cardiac arrest survivors. But we also have the mug with this logo on and another design. So, there's some options. We also have a bottle that you can use both to store something cold or something warm. your coffee or some cold beverage in summer. Now, if you are not so much interested in our merch, but you do want to support the project, then you can also leave a donation using Ko-fi. It's the same principle as leaving a donation. So you can buy me a virtual coffee, which I will use to continue doing this project, not to go and buy a coffee per se with. I will put a link in the description of this episode, or you can also go directly to heartwarriorproject.com/get involved to find the same page with both the merch and to leave, a place to leave a donation. All right, let's return back now to the conversation with Dr. Saenen and Dr. Loeys. Another question that I had from someone, from Marcus, who is actually also a cardiac arrest survivor that I had on the show from Sweden. So my SCA is idiopathic, for now at least, awaiting DNA sequencing for possible hereditary diseases. What type of diseases do you typically find when doing a genetic testing in search for something that could have caused SCA, a sudden cardiac arrest? One thing that I added to it, I also just posted it in the chat, is what are some of the biggest challenges you face in diagnosing rare genetic disorders related to cardiovascular diseases? And how can advancements in genetic testing help overcome these challenges?
Yeah, very good questions.
Yeah. So maybe to address the first one is when somebody survives an episode of sudden cardiac death, of course, we first always do some clinical investigations. And these will mostly help us to identify structural problems. It could be a problem with the coronary arteries, as Johan explained. It could point towards a heart muscle problem. The muscle could be thickened, which we call hypertrophic cardiomyopathy, or dilated. We can look at aorta, so that's mostly looking at structural problems. If that all turns out to be negative, and with negative in medicine we mean normal, then we look at a group of diseases that's mostly related to the electrical conduction in the heart, which might be more difficult to pick up on routine exams, because it's happening at one moment and disappears the next moment. So you might not be able to catch it, even if you do like a 24-hour registration of the heart rhythm, then it's possible that within those 24 hours you don't see it. Mm-hmm. So in that group, the genetics can help, because we do know quite a lot of genes that cause electrical conduction problems without structural abnormalities. And they're finding a genetic variant that explains the occurrence of an arrhythmia can give you a definite diagnosis of an inherited cardiac disorder. I think one of the challenges in genetics is to distinguish pathogenic and non-pathogenic variants, which is not always easy, because if we do a genetic test of many genes, we will always find variation, and then it's our job to judge whether the genetic variation is really causal or whether it's just a variation of the normal. So that's definitely a challenge. Yeah. And when the person survived the sudden cardiac episodes, then we can go back and see if we can provoke the arrhythmias based on the phenotype, or we can search more in depth to the electrical abnormalities that we expect to see. So there it's possible then to make a correlation between your genetic finding and the occurrence of the electrical abnormalities.
Mm-hmm. What do you mean with provoke, patient, actually?
For example, in Brugada syndrome, we do know that there is a genetic predisposition, which is most convincingly caused by genetic alterations in a gene that encodes a sodium channel that's present in the heart. Mm-hmm. For example, by doing an Ajmalin testing, where you additionally block the functioning of this channel, you can provoke the typical electrical abnormalities that lead to the diagnosis of Brugada syndrome. So if you can find those, it adds evidence for the fact that the variant that you identified is really causing abnormalities. And yeah, depending on the disease, we have different types of tests that can help us to make the clinical diagnosis more clear or more overt.
Yeah. But it's very important that we let ourselves be led by the phenotype. By the phenotype, we mean the way the disease expressed itself.
Yeah.
And in patients that have been sort of like arrest survivors, it is the first thing that we always ask is, what were the circumstances? Was the patient at rest? Was he doing exercise? Was there an emotional stress? Was there a sudden loud noise? Was he swimming? Was he running? Because that is one thing. Each of these diseases has this distinct way of manifesting itself, presenting itself. And of course, there is lots of overlap between those diseases. So that's the first thing. And then we do the phenotyping. So we do all the cardiac investigations. And if we don't find anything, then it is what we call idiopathic. And idiopathic is just a very, very expensive word to say we really don't know what was causing the sudden cardiac arrest. And then of course the genetics can really lead the way. And the younger the patient is, the more often we find electrical diseases like long QT syndrome or CPVT-Brugada syndrome. The older the patient becomes, the likelihood of finding a genetic mutation in one of the cardiomyopathy genes, so the genes that cause myocardial tissue disease, so the chances become higher, the likelihood becomes higher. So that's more or less, but sometimes also in children we find very severe hypertrophic cardiomyopathy, so it's still possible, but that of course we will find with the cardiac investigations. So it's really the combination of the two. That's why we do our consultation always together. So we have best of both worlds. We can integrate all the cardiac data of the case together with the genetic data and try to work out what happened. Even if the patient didn't survive, we don't have an autopsy, then sometimes it becomes difficult. But we sometimes can work it out by putting everything together from what happened to the patient and also from what we learned in the family members, first degree relatives.
So wait, the phenotype can lead to the genotype in a sense, or is that not correct? Yeah.
Yeah. Or the genotype sometimes leads to the phenotype, but they always go hand in hand. I think one of our typical characteristics of our clinic is the multidisciplinary approach. We also have monthly meetings where we really sit down with the people from the lab to look at those variants, to put the clinic next to it, and to find a correlation between the two of them. And so the genetics never stand alone.
And why do some patients or some people who survive a sudden cardiac arrest stay idiopathic? Or do you...
You're not smart enough.
Yeah, I think that's true.
Yeah. So we have 21,000 genes of about, let's say, 120, 150. We do know their link to cardiac disease. In total, in genetics, I think we probably know for 6,000 genes what they do. So it means that there's still a lot of genes. We have no idea what they do and if what their phenotype is.
But I also think that it may, in some cases, be just bad luck, because the heart is such a complex organ, and the electrical balance of the heart is really it's actually a little wonder that it works for about 100 years without glitching, without having hiccups. And so there are 100,000 beats per day, each day. And sometimes there's these extra systoles, so an extra beat that is there, and everybody has them. But if that beat happens to occur at the wrong time, so there's always a vulnerable stage of every cardiac cycle, of every electrical cycle, and if that beat just happens to fall on the wrong timing, then it can induce an arrhythmia. And of course, there are these redundant mechanisms in the heart that will stabilize and prevent this. But it can be just bad luck as well, I think.
Right.
And of course, these are not hereditary conditions then, so that's only one in the family. So sometimes I think some of those patients just have a lot of extra systoles that can fall at the wrong timing, and that can cause arrhythmias. We all have this vulnerable phase where during every beat of the heart that is vulnerable to inducing arrhythmias. We know this from the lab. If we start pacing in that vulnerable period, we can induce arrhythmia in every person, even with a completely normal heart. So that means that it can also happen just by accident.
Yeah.
And in some cases, I also think that can be the case. But I think that's rare. Most of the cases, I think we just don't understand the disease yet.
Yet, yeah. Let me. This is sort of a question, a follow-up question in a sense to it. So how can we better integrate genetic screening into the prevention of sudden cardiac arrest? Because, I mean, when I had my cardiac arrest, only then my mom and my sister were asked, which makes sense in a way, I guess, right? To also get themselves screened. But it would be better if we could do this way earlier and not have the cardiac arrest happen in the first place.
Yeah. I think that's exactly right. So I think the first thing that we all have to be aware of are the alarm symptoms. So in these hereditary diseases, it has been described that about in 30% of cases, the first symptom is the sudden cardiac death event itself. So in 70% of cases, there are these symptoms that happen before the sudden cardiac death event. And even in those 30%, usually, if you really ask patients, was there anything, then they say, well, there was. I didn't have any symptoms. But if you really start asking the right questions, usually something already happened before, but the patient didn't recognize it as it may be being a symptom from an underlying cardiac disease that hadn't been discovered yet. And these symptoms are what we call alarm symptoms. And the first one is syncope. Is sudden fainting. Patients don't feel it coming. There are no what we call prodroma, no symptoms before the syncope. It's just as if somebody switched the light off and the patient suddenly drops on the floor. They come round completely after a couple of seconds. It doesn't take minutes to come round, and it is as if nothing happened. This is what we call a sudden syncope, and it is always an alarm symptom. It should always lead to a cardiac investigation because it may still be something trivial, not important, not dangerous, but there may be a cardiac condition underlying it that can cause these lethal arrhythmias, that can cause this sudden drop in blood pressure, that can cause this, that will lead to this sudden syncope. So sudden syncope without any warning signs, without any prodromi, is always a red flag that should lead to a cardiac investigation. Mm-hmm. And the second one, of course, is referring to symptoms that may point towards imminent myocardial infarction. Is what we call angina pectoris. So it's this pressure on the chest, especially during exercise and in a later stage when it becomes worse, also during rest, like they are feeling that there's a weight pressing down on the chest. That is what we call angina pectoris, and this also warrants cardiac investigation to look whether the coronary arteries are still in check and there's no lack of oxygen during exercise or in a later stage when it becomes worse, also during rest. And it is also important to point out that angina pectoris can also occur in children. And this may be a sign of hypertrophic cardiomyopathy. So also in children, for GPs and physicians, it is important not to dismiss angina pectoris because it may lead to a diagnosis of a severe hypertrophy or thickened cardiac tissue even in children. So really important warning sign. Another one is heart failure. Of course, if patients have develop shortness of breath or develop edemas, peripheral edemas, the exercise tolerance goes down. These, of course, are signs that something may be wrong with the heart, and this also warrants, of course, a cardiac investigation. Another red flag and warning sign, of course, are symptomatic palpitations. So if the heart starts beating funny and it becomes a little bit woozy or a little bit black in front of the eyes, that means that probably there's an arrhythmia. There's a rhythm disturbance that may cause a drop in blood pressure, and also that is a symptom that really warrants investigation by a cardiac specialist. So the next red flag, of course, are the unexplained events. So where we have people that are good swimmers that suddenly got into trouble during swimming, almost drowning or having a near drowning incident. Patients with unexplained epilepsy. So these patients that had several epileptic insults, but where the neurologist was never able to prove epileptic activity on the EEG. This is also something that is a bit strange. And we have these syncopes or these fainting events that present as epilepsy, but that really are due to arrhythmias, malignant arrhythmias happening in the heart that cause blood pressure drop, and this blood pressure drop in the brain then causes the epileptic activity. Also, these traffic accidents that are strange, where the patient did not brake at all. So these are things that we always ask about, because these may also lead to underlying cardiac disease. And of course, the last one, which is always very important, is family history. So if there's already a patient in the family that suddenly died at a young age, so younger than 45 years of age, or had sudden collapses, or had alarm symptoms like the ones we've mentioned, of course, that is really, really important, because if the patient in front of you is a family member of that other person, this may lead to hereditary disease being there in the patient in front of you. So these alarm symptoms are super important. That's the first step to try and prevent sudden cardiac death. And of course, if it happened, it is, like Bart already mentioned, it is super important to ask for an autopsy. It is, in too many cases, patients have been, the death certificate has been filled in with natural cause of death. But you really cannot know. If you didn't know the patient on beforehand as a physician, then you really cannot know, and you have to ask for an autopsy. And then the pathologist can take a good DNA sample that can be used for molecular and genetic analysis afterwards.
Yeah, I think we can also not stress enough the importance of a family history. It sounds like a little bit obvious, but too often just a single question is asked, is there anything in the family? And then the answer is almost always no. But then when you start asking in detail, what about your brother? What about your father? What about your grandfather? We always find important leads. And I'm happy to see that in recent guidelines of the European Society of Cardiology, it's really stressed that taking a detailed family history on all first and second degree relatives is really essential in the management of sudden cardiac death. And I think we need to educate the next generation also about this, so that it's not forgotten and must be part of a regular investigation always. So. Yeah.
And do you both feel like in Belgium we have medical screening when we're children, right? Do you feel like we're doing enough there around the heart? Like in terms
again,
of like
I think,
testing it?
Yeah, there has been a study of the KCE on that, the Kenniscentra.
Yeah.
So a couple of years ago, they looked at whether doing, for example, an ECG in everybody or doing an echo would help, and the answer was no.
Oh, really?
Because it's not sensitive enough, and you make a lot of people anxious about something that's not there. So really asking for these alarm symptoms and doing the family history is much stronger in detecting problems than regular screening. Yeah. So it should be really dedicated to people where there is these alarm symptoms that Johan discussed, or to children where there is a significant family history.
Yeah. these diagnoses are usually quite complex and difficult, and you really need specialists that even within the cardiologist community, you really need specialists that are aware of the intricacies of these and the little details, the transient, subtle changes that can sometimes be there, and then 1 hour later are no longer there. So it really requires specialists to look for these diseases and not overdiagnose, because that's also a really big problem, because the overdiagnosis of a disease can be so devastating to a person's life.
Yeah.
So it really needs to be, so the trigger for these kinds of investigations, in my opinion, should be that there's been an alarm symptom or that there's already someone in the family that had a disease. So learning these alarm symptoms, I think that's the first step to really get to this. And if everybody knows those alarm symptoms, just like everybody knows doing CPR the right way at the right time, I think that will help a lot. So I think that should also be introduced in the schools to learn to care for one another and to recognize the symptoms. We once had a patient that was in the swimming pool from a water glide, and he fell asleep on the water glide, and he was fast asleep at the bottom of the pool.
Wow.
Which of course it was not a sleep; he had a syncope, and it was a cardiogenic syncope. So sometimes people really do not attribute the fact that something happened, that it may be due to something sinister happening there in the heart.
Yeah. Yeah, so education. Yeah.
Yeah.
Let me ask both.
Patients and doctors.
Let me ask two last questions, because you both already had a long day. It's quite late, so let me ask two more questions. One that I think is also quite an interesting one, and interesting in terms of that many people have questions about it. So this is a question from Karen, and it's about magnesium. So, hey Ellis, I keep reading that magnesium is meant to be good for reducing ectopics, and I had to look it up what that was. It's a type of arrhythmia or abnormal heart rhythm. If so, which type of magnesium? Now, supplements in general are quite, popular, for better or worse. So magnesium falls under that. Is magnesium good for the heart? And also if you have a heart disease?
Yeah, so magnesium to some extent is good for the heart, but so the evidence for that is quite limited, and for ectopics, like Karen was referring to. So ectopics are extra beats, so extra stimuli. So extra beats either from the atrium or from the ventricle. So the evidence for that is quite limited. We do know that arrhythmias in certain types of diseases, such as long QT syndrome, occur more often if there's hypomagnesemia. So when there's a state where the magnesium content in our body is low. So in those cases, of course, substituting magnesium will reduce the risk for having these arrhythmias in long QT syndrome. But also it has been shown that for long QT syndrome, again, that even if the magnesium content in the body is normal, that substituting magnesium is probably beneficial. And also when the arrhythmias in long QT syndrome, which we call torsade de pointe, which is a polymorphic ventricular tachyarrhythmia, then also magnesium is beneficial to help solve the arrhythmic events and the electrical storm that might be there. Also, if there's intoxication with an old medication that in Belgium is still used from time to time, which is digitalis, when there's intoxication, then also magnesium substitution can also help resolve the situation. So all in all, I don't think it is wrong to take it. For the ectopics, I think the evidence is limited. It has been shown to have a more somewhat electrically stabilizing effect on the heart. But as far as supplements, I think if you just have a healthy diet, you don't think it is really necessary to take a lot of supplements. So personally, I'm not taking magnesium. I'm a cardiologist. I know a lot about arrhythmias, electrical stability. I think it is. I think if you have a healthy diet, I'm not sure that it will that there will be a lot of benefit.
Okay.
Take
And
these supplements. Yeah.
in terms of any other supplements, because again, many people, wonder about it. Is there any other supplements that has been shown with solid research to be good for the heart and also for heart disease?
Difficult question. Again, I think if we all keep a healthy lifestyle, I think that
A balanced diet.
with a balanced diet, like following the food pyramid and exercising 3 times a week, not smoking, I think that probably is more important than taking a lot of supplements. We are designed to function with a normal healthy diet, to exercise a lot. So I think that's the easiest way.
All right. I mean, there were some more questions, but again, in terms of time, I don't know if there was one on, I mean, because you have the questions too, if there was one that you both really wanted to still dig into. Otherwise, I have a final end question just to kind of round it up.
Maybe I will just briefly touch upon the question from Sana, because that was maybe something also that was important.
So
the difference between the regular ICD and CRT,
yeah,
maybe.
yeah. So
Because
that's
just
true.
takes minutes.
That's a good question. So let me just read it. So from Sana, what is the difference between a regular ICD and SRTD? Sorry.
CRT.
Oh, wow.
CRTD.
CRT. Yeah, it's getting late for me too. And what are the possible advantages of CRTD? And I kind of added to it as well. How do you decide whether to place an ICD in someone or not, and which kind?
Yeah. So maybe let's start with the last question, because that's the introduction to the ICD topic. So we put in, as a society, we decide that so we have patients with a cardiac condition that have an increased risk for sudden cardiac death.
Mhm.
And of course, a patient that already experienced sudden cardiac death has a very high risk of recurrence, or at least that's what, as a society, what we think. And in that case, we cannot predict whether it is recurring, when it is recurring, how often it will recur, and how detrimental the arrhythmias will be. So the only way to protect those individuals is by giving a device that will monitor the heart rate and the heart rhythm continuously. And if the heart rhythm is completely normal, the device won't do anything. It will just sit there and watch the rhythm. But if an arrhythmia occurs that is malignant, potentially leading to a lethal event,
Mhm.
then the ICD will be able to treat the arrhythmia effectively and stop the arrhythmia and return the rhythm to the normal rhythm, and solve the situation.
Yeah.
So that's why we put in ICD. So if we, as a society, based on our risk models for each specific disease and for each specific individual, find that the risk for sudden cardiac death is such that we are not really sure that if we let the patient go just with medication, that the patient will survive for a certain amount of time, then as a society we will decide to implant an ICD. Yeah? Knowing that the ICD will protect the patient, but also knowing that an ICD on the long run, on a lifetime basis, can also induce complications and also can lead to real problems for the patient. So there's always the balance that we have to make between the risk for sudden cardiac death that we can cover with the ICD and the risk for complications that are actually induced by implanting the ICD. And of course, on an individual basis, the risk is low. But if we look at populations of ICD patients on the long run, the amount of complications is not so low. So that's the balance that we have to make every time we make a decision.
What are complications, by the way?
That brings me
like the wires or the leads, or what is a complication that is?
Yeah, so complications could be all sorts. So of course the ICD will give can give electrical shocks to convert a malignant arrhythmia towards the normal rhythm, but sometimes the algorithm of the ICD makes the wrong decision and will give a shock when it is not necessary. When there's a normal rhythm, for instance, when the patient is doing a physical exercise, is cycling, and suddenly the ICD thinks that there's an arrhythmia and it will give a shock. Well, the rhythm is completely normal, so that's unnecessary. That's called an inappropriate and, of course, unnecessary shock. This is really something that we like to avoid. Of course, when we implant the ICD, there can be all kinds of procedural complications, such as pneumothorax or hemothorax. There can be infections where the lead gets infected. If the system is infected by a bacterial infection, giving antibiotics will not solve the issue. Then we have to remove the entire system. Sometimes also the lead can break or can wear out where it no longer functions. Then we have to replace the lead. Sometimes there's device-related issues. So there's a whole bunch of really bad complications that we really like to avoid. And so this is also something that we have to take into account when making the decision. And of course, if the risk for sudden cardiac death is very, very high, the decision is very easy. But sometimes the risk for cardiac death is somewhere in the gray zone. And then, of course, we have to think what is best for the patient. Sometimes we do this also in a very open conversation with our patient, right, which we call a shared decision. So that's these are things that we do on a daily basis. Yeah. Brings me to the difference between ICD and CRT. So the ICD in itself will just protect against malignant arrhythmias. And in some cases, we have an electrical disease, such as Brugada syndrome or long QT syndrome, where there's merely electrical disturbances and no real heart failure. But in some diseases, such as in laminopathy, for instance, there's also heart failure, where there can be a asynchronous contraction between the left chamber and the right chamber, and when those chambers contract asynchronous, this is not preferable. This will also reduce the function of the heart, making it less effective. So in order to solve that, we can put in an ICD with an extra lead that goes also to the left ventricle, and we can give electrical impulses that from at both sides, to the left and the right ventricle together, resynchronizing the contraction of both chambers. And that can really augment the function of the heart, so really making the heart more effective in its pump function. So this can also be one way to treat heart failure. And of course, depending on the disease, depending on the profile, depending on whether there's heart failure or not, we will choose the platform of the ICD. We can do this either transvenous with a lead inside the vasculature towards the heart. We can also put an ICD under the skin with the lead above the sternum, above the bony thing in front of you at the chest. And there's a new platform which is called extravascular ICD, where we put the lead under the sternum, so under the bone of the chest in front of you. Yeah.
And the CRTD? So
the CRTD is the resynchronization device, where we it is an ICD. But also, so it's a cardiac resynchronization therapy ICD. So that is the device where we put one lead in the right chamber and one lead in the left chamber, and those will give pacing on both sides to resynchronize the contraction of both chambers.
I don't know if it's this kind of ICD, but isn't there a new kind of ICD that the wires don't have to go in the heart?
Yes, so these are the two latter platforms that I talked about. So you have the subcutaneous ICD. Yeah. So this is the ICD where that is put under the skin on the left hand side, and there the lead goes not inside the vasculature and not inside the heart, but it goes over the chest wall, under the skin, of course, and over the sternum, so over the bone in front of you.
Right.
And then there's a second one, which is quite new, which we call the EV ICD, or the extravascular ICD, where again the device is put on the left-hand side under the skin, but where the lead goes over the wall of the chest, but under the sternum, so under the bony part of the chest wall in front of you. So it is actually inside the the chest. But only the electrical part of the lead that can shock will be inside the chest, and the rest of it will go over the chest wall to the ICD box, which is under the skin on the left hand side, and this is called EV-ICD.
All right, got it. Okay, let's wrap up the interview, and let me ask one final question. So this is something that I don't think patients or people who are not doctors don't often hear, but it might be interesting. What are actually some of the challenges or maybe frustrations that we as patients or people in general who aren't doctors don't know or don't really see that you both as doctors often face, that you wish patients or other people would, understand better?
That's a difficult one. I think maybe the fact that the answers are not always black and white, and that there's a lot of gray, and that we really try our very best to explain that gray to the patient, but that's not always easy. I think that's probably a challenge that patients are not so aware of, because it's normal that they expect from the experts and the specialists a black
clear
or white
answer.
Clear answer, and unfortunately it's not always there. That, I think, is sometimes difficult.
For me, I think the challenge there also relates to the same. I think we are always dealing with risk profiling, and risk is something that may happen, but it may also not be. And even if we, based on what we know and what we do and all the investigations that we do, if we find low risk, it does not mean that it is zero risk. Actually, even if there's no cardiac condition, everybody has a certain baseline risk of dying suddenly, dying prematurely. So low risk, even if we are talking about this to patients and also sometimes other physicians, referring physicians, low risk doesn't mean that nothing is going to happen. It can still happen something to that patient, and this is something that also as a society I think we have to learn to deal with that. There is no guarantee in life, unfortunately, and
that's the only guarantee in a way.
There is. So and people are expecting sometimes that we give guarantees about this and that, and unfortunately that is not possible. We are not magicians. We are not predicting the future. We are predicting risks, and based on that risk, we try to find the best path and make the best management for each individual patient based on the knowledge that we have at this time. And in 10 years' time, we will know a lot more. We will be probably a lot better in what we do compared to what we are doing now. But at the moment, we have to use all the tools and all the data that we have right now. And I think also to end with a really positive note, I think there are some really interesting things that are happening. I think risk prediction in 10 years' time will be completely different and will be probably a lot better with new AI tools that are currently under development, also here in our center. We expect a lot from it, and I think it will change the way we look at cardiac diseases, at sudden cardiac death predictions and risk predictions. It will change the whole world, and it will go. I think it will go really fast also.
Specifically, so, AI.
Come and see. AI. Because to give one example, so we take ECGs. So these are the electrical measurements of the heart every day, and as a cardiologist, we are trained to look at them and make diagnosis based upon the features that we see on those ECGs. But there's so much more data in there that we just are not aware of. And just by analyzing ECGs with AI models, I think we can come to much earlier diagnosis of disease that may not even have manifested in a structural way. And by making diagnosis more early, we can treat more early, and we can make better predictions on risk. We can better prevent risk for sudden cardiac death and things like that. So it will open up a whole new avenue of tools and of ways to ameliorate sudden cardiac death management compared to what we have been doing and what we're doing at the moment.
That's exciting. It's very exciting, actually. All right. Well, Dr. Saenen, Dr. Loeys, I mean, thank you again for taking the time and for giving the great answers and for wanting to be here on the show. All right, and that concludes this interview with Dr. Saenen and Dr. Loeys. I really hope that you gained some useful information out of this episode on this very complicated but very interesting topic. If you liked the episode, then well, don't forget to leave a rating or possibly to leave a short review. It really helps to push out these interviews more into the world. If you will take just a short moment of your time, thank you truly for leaving a rating or a review. Don't forget also, of course, to subscribe if you like this episode, of course, and also check the description if you want to ask to the next cardiac health expert your question. In the description, I will put a link to the newsletter. So yeah, sign up, as I will bring out the announcement there on the newsletter. You can also go directly to heartwarriorproject.com/newsletter, or follow us on Instagram at heartwarriorproject. As on those two places, but mainly the newsletter, I will send out the announcements when we have another cardiac health expert. With that, thanks again for being here, and who knows, maybe I have the chance to welcome you again on another episode. Until then, this is Loeys signing off.